There we go. So we have reassured patients and families that less than 1% of individuals treated for acute pain would become addicted to opioids. That conclusion was based on two very classic studies. Marks and Schechter found that less than 1% of hospitalized patients who received 100 milligrams of IM Demerol every 4 hours became addicted. How many of you are giving 100 milligrams of IM Demerol for pain every 4 hours IM? Okay. Then Porter and Jick found that of 12,000 medical inpatients who had received at least one dose of an opioid, only 4 were later diagnosed as addicts, and all 4 of them had previous history of substance abuse. Now, you can first discredit these studies because they're 30 years old. But those of you who lived, and there's a couple of you out there, in the 70s and 80s, may be aware that there was substance abuse at that time. But now our current estimates is that 6 to 15% of Americans are currently addicted to drugs. So I don't think it's fair for us to say that pain somehow protects you from becoming a substance abuser. What's changed since the 70s and 80s is our availability of opioids. As we've gotten better at treating pain and using opioids to treating pain, there's more of them out there. And as prescribing opioids has increased, so has substance abuse. The trend estimates from 2004 to 2011 shows a 183% increase in the rate of opioid-related emergency room visits. For specific opioids, the greatest increase in this period occurred with hydromorphone products at over 438%. But raw numbers of ED visits were associated with products containing oxycodone, morphine, hydrocodone, fentanyl, and methadone. In 2012, 37 million Americans over 12 years of age had used opioid pain relievers for non-medical reasons for some time in their life. As you know, improper use of opioids can result in serious adverse effects, including overdose and death. But our teens are not capable of estimating those risks. Drug overdose deaths in the United States have more than tripled since 1990 and have never been higher. In 2009, over 14,000 deaths involved prescription opioids, more than cocaine and heroin combined. But this data can also be misleading because the findings do not necessarily mean that the opioid caused the death, but rather the opioid was in the body. The rise in overdose deaths in the U.S. also parallels a 300% increase in prescribing since 1999. About half of prescription opioid deaths involve at least one other drug, including benzodiazepine, cocaine, heroin, and alcohol is also involved in many overdose deaths. Non-medical use of prescription medications is associated with higher rates of alcohol, tobacco, and other drug use amongst adolescents and young adults. The National Survey on Drug Use and Health found that in the past year, 6.5% of 12 to 17-year-olds reported non-medical use of controlled substances, and 9.4% reported non-medical use of controlled substances in their lifetime. And remember, their lifetime was 12 to 17 years. Of 18 to 25-year-olds, 12% reported non-medical use of controlled substances in the past year, and 24.4%, almost 1 in 4, reported non-medical use in their lifetime. These are our medical students. So in 2011, the same national survey found the drug category with the largest number of recent initiatives amongst persons aged 12 or older was marijuana, followed by non-medical use of pain relievers. Now, when I'm asked to talk to PTAs, they all want to know about cheese and bath salt and K2, and what I tell them is look in your own medicine cabinet. That's what kids are abusing. 1/5 of U.S. adolescents report sharing prescription drugs, perhaps medications that you've prescribed. How many of you have offered a friend or a relative a prescription drug? An antibiotic, an allergy medicine, a Xanax, a Phenergan, a Vicodin? How many of you have been offered one or asked by a friend or relative if you have one that they could use? According to a survey of seniors in high school who abused prescription drugs in the past year, 46% of them had been given them for free by a friend. 34% purchased them from a friend, 30% merely abused the prescription they already had, perhaps a prescription you gave them for postoperative surgical pain or after trauma. 10% got them from a relative and 3% bought them from a relative. And over 4% took them from a friend or relative without asking. Perhaps we gave the prescription to the friend or relative for postoperative pain or after a trauma. The National Survey of Drug Use, I think that's my phone. The National Survey of Drug Use and Health results concur. Most diversion occurs amongst family and friends, with misuse of prescription opioids stemming from a prescription previously obtained from a physician. So why do teens abuse prescription drugs? So when asked, 56% of teens stated they somewhat to strongly agreed prescription drugs were easier to get to illegal drugs. I mean, imagine, you got to go in a dark alley, right, to get the illegal drugs. You can just go in your bathroom to find prescription drugs. And 62% stated they somewhat to strongly agreed that most teens get prescription drugs from their own family's medicine cabinet. So how can we identify these adolescents? Now, this is research by Boyd, and she hypothesized that adolescents who engaged in non-medical use for sensation-seeking, in other words, to get high or to create an altered state, were more likely to report other problem behaviors than those who were non-users, who had never used a prescribed opioid, medical users who were prescribed them and were using them correctly, or self-treaters, those who were engaged in using non-medical use for self-treatment of perhaps pain. She asked over 900 7th through 12th graders in Michigan, using a random sample, web-based format, on how many occasions in the past 12 months have you used a sleeping medicine, sedative analgesic, stimulant, or pain medication that was not prescribed for you. And what she found was 60% reported being non-users. They weren't using any controlled substances and hadn't been prescribed them. 29% reported being medical users. 8% reported being self-treaters, and 3% reported using sleeping medicines, sedatives, anxiolytics, stimulants, or pain medications that were prescribed for them for sensation-seeking. By the classic abuse definition, this is 11%, which is exactly where we thought we were nationally. Teens most commonly reported using prescribed analgesics for pain. 33% had been prescribed an analgesic in the last year, and 43% recalled taking an analgesic for pain sometime in their lifetime. And note, most often it was for third molar extraction. I'm going to talk about that again later. But teens also most commonly reported using analgesics that were not prescribed for them. 10% in the last year, 15% in their lifetime. But remember, I asked, how do I identify these patients? So her hypothesis was right. Adolescents who engaged in non-medical use for sensation-seeking were more likely to report illicit drug use, gambling, binge drinking, sexual activity, and depression in the last year than non-medical users, medical users, and self-treaters. Sensation seekers were more likely to report problems with impulsivity in the last year than non-medical users, medical users, but not the self-treaters. There was no difference in reporting of being disciplined among the four groups, perhaps suggesting that these are the kids that are not being screened for these high-risk behaviors, and they're not getting caught. These aren't the bad kids. These are the kids who are doing okay, we think, but they're involved in these behaviors. Now think of your accidental trauma patients. What are their risk-taking behaviors? Are any of them impulsive? Are they sensation seekers? Sensation seekers look like teens with many problem behaviors. So what are you going to do about it? What changes can you make when you return to work? So here's some ideas. Before initiating opioid therapy, you need to assess for substance abuse, misuse, and addiction. Proper patient selection is critical and requires a comprehensive benefit to harm evaluation and weighing the positive effects of the opioid and the functional gains against potential risks in every single case. History of current or past substance misuse and social history, including family history of substance abuse and psychiatric disorders, are also relevant. These may predict poor responses to opioid therapy, and patients with unstable or dysfunctional social environments require additional monitoring during treatment. A substance abuse history certainly does not prohibit treatment with opioids in every case, but may require additional monitoring and assistance from persons who have expertise in managing pain, addiction, and other mental health concerns. And in some cases, however, opioids really are not appropriate. So before prescribing, you want to use there's a variety of self-administered and provider-administered screening tools available based on patient characteristics. These may be helpful for risk stratification. These tools differ in their psychometrics and intended use, and not all are validated in the adolescent patient. Patients sometimes underreport drug use to medical professionals, so you can also use tools like urine drug testing and the prescription drug monitoring programs. These may help provide accuracy with the patient's self-report. It's also, though, important to understand the limitations of these methods. So while urine drug testing, for example, is a tool that may assist in identifying substance use or misuse, it does not in itself diagnose a substance abuse disorder or addiction. So here's an example of an opioid risk assessment tool, and I'm going to give you an example of a case I was involved in. This is a patient with chronic recurrent osteomyelitis who was having pain that we actually got her pain very well controlled on 10 milligrams of OxyContin twice a day. And refilled her prescription monthly for quite a while, and then she showed up in the ER with extreme pain, those they're probably calling just now, with the, what do we do with this patient? We're concerned. And on interview, what she shared with me was that she wasn't taking her prescription medicine, she'd been hoarding it to kill herself. So I got psych involved, and what she reported to psych was, no, that wasn't really true. What was actually happening was her mother and her sister were taking her prescription drugs, so that because they had substance abuse problems. When I saw this patient, there was no family history of substance abuse, no history of personal substance abuse. She was 14 years of age. She did not have a history of pre-adolescent sexual abuse. She was depressed at the time, so her risk was a 1. Now, obviously, after this ER visit, there is a family history of substance abuse. There's a personal history of substance abuse. She's still only 15 years of age. She still has not had a pre-adolescent history of sexual abuse, and she's suicidal. So her risk assessment has increased dramatically because all we had was self-report to do a risk assessment. So something else that you can use is your prescription drug monitoring programs. These are available in all states except Missouri, Nebraska, and New Hampshire. The prescription drug monitoring program allows you to track prescribed controlled substances as well as other drugs of concern by state that have been dispensed to the patient. So this idea of I write the script, does the patient actually get it? I can now see when it's been dispensed. For how they are used in each state varies. I know the most about Connecticut's. In Connecticut, it just became law that all prescribers of controlled substances are required to register with the prescription drug monitoring program. Of course, we're not required to use it, but we are required to register. The tool's online, and the record of dispensed controlled substances is available immediately as long as you're a registered prescriber. So in other words, if you're the nurse in the ED, you can't get it. If you're the trauma coordinator, you can't get this information. If you're a resident, or if you're from the Division of Children and Family Services, you can't pull this information on a patient, but the prescriber can. Another limitation in Connecticut is, I've lived in Texas for over 20 years. It's a big state. Connecticut's, like this big. And one of the things I noticed is I'd write prescriptions and patients, it wouldn't come up there on the Connecticut Prescription Drug Monitoring Program because they'd go to Massachusetts to have it filled, or Rhode Island. I can't see what was dispensed in Rhode Island or Massachusetts, so we have no reciprocity. I can't get that information to monitor the patients. This is a sample report that was made for education. This is not obviously one of my patients. In this case, the patient appears to have 4 different addresses in 6 months, or there's 4 John Smiths with the same date of birth living in Connecticut. There's 5 different prescribers in 6 different pharmacies that dispense prescriptions listed in the last 6 months. For each prescription, for Schedule 2 through 5, the report includes the fill date, the product strength, the quantity dispensed, and the numbers of days. And the numbers of days always bothered me because this is calculated by the pharmacist based on what you wrote. So if you write 1 to 2 pills every 4 hours as needed for pain, and you dispense 30 pills, this is only going to be 2.5 days worth. And so when your patient says, well, you only gave me 2.5 days worth, you may not have been thinking they were going to take 2 pills every 4 hours, but that is right there on their prescription bottle. It also tells you who the prescriber was, when it was filled, and how they paid for it. Prescriptions obtained from multiple providers or dispensed from a variety of pharmacies or paid for with cash are indications of possible controlled substance diversion or non-medical use. So one of the questions that last night I was talking to some of the faculty, I always like to ask is, do you know which is worth more on the street, Percocet or heroin? Percocet. So one of the things to keep in mind is I had always wondered why, when people talked about Percocet or hydrocodone being an entry drug to heroin, why that just didn't make sense to me. But if you can sell what you prescribe that maybe you bought for $10, and you can sell it for $10 a pill, that buys a lot of heroin. Now let's talk about another tool. And this is urine drug testing. Now, my disclaimer is I'm not a toxicologist or an expert in urine drug testing, but because that validity of drug user self-reports on substance can be variable, the urine drug test can be very helpful as a supplement to self-report in guiding continued treatment. The presence of an unprescribed opioid or illicit drug or absence of a prescribed opioid can be a marker for problematic issues. Such unexpected urine drug test results that are not consistent with the history gathered from the patient are useful to support a decision to refer a patient to a specialist. And when I watched the talk about burns and listened to the stories and then the injuries, this is exactly what I often use urine drug testing for. Interpretation of urine drug testing is challenging and requires an understanding of the opioid drug metabolism, pharmacokinetics, and limitations of testing methodologies. Clinicians should also consider a differential diagnosis for abnormal urine drug testing, including drugs of abuse and addiction, self-treatment of poorly controlled pain, psychological issues, or, of course, diversion. In most clinical settings, testing is done with class-specific immunoassays, which classify substances as either present or absent according to a predetermined cutoff level. The advantage of immunoassays is their ability to rapidly test for multiple drugs. The disadvantage is that the immunoassays vary in what the range of the compounds that they are detected. If a definitive identification of a certain drug is required, you're going to need more sophisticated laboratory testing. And immunoassays are also subject to cross-reactivity. So the most common immunoassay is for naturally occurring opioids. So it's very responsive to morphine and codeine, but does not distinguish which one is present. Opioid immunoassays are lower in sensitivity to semi-synthetic opioids like oxycodone or hydromorphone, and so even high concentrations in the urine may not be reliably detected. A well-meaning resident recently decided to urine drug test one of my patients that was in the hospital who had had a previous positive test for an unprescribed drug. What the resident was amazed at and called me immediately was the patient was on a hydromorphone PCA and the urine drug test did not show that she had any hydromorphone in her system, and he couldn't explain that. And so when I tried to explain that our cutoff in the hospital is much higher than what I use in my clinic, and that's why they weren't even picking up what we knew we were actually giving into to the patient, and that we did not have to test all the nurses that had taken care of that patient that day. A negative result does not exclude use of an opioid unless an immunoassay directly toward that particular semi-synthetic opioid molecule is used. Only immunoassays specifically directed toward the molecule will detect those synthetic opioids like methadone or fentanyl. The detection time of drug in urine indicates how long after administration the person excretes the drug and its metabolites at the concentration above a specific cutoff. Although it's governed by various factors, the detection time of most drugs in urine is 1 to 3 days. Long-term use of lipid-soluble drugs like marijuana, diazepam, ketamine may extend the window for a week or more. There are some drugs that are very rapidly metabolized and so rarely detected in urine. For example, cocaine is rapidly metabolized. So identification in cocaine in the urine specimen indicates a very recent use, like on the way to the hospital. Therefore, the drug tested, in this case, usually is directed towards the metabolite. Be aware that immunoassay test panels can vary. So what I'm using in my clinic is obviously different than what we use in the hospital. And so you need to know what are the cross-reactivity patterns and the cutoff levels. Detection of particular drugs by specific drug class-specific immunoassays depends on the structural similarity of the drug or its metabolite to the compound, but not always. There is cross-reactivity from compounds that look nothing like opioids. For example, quinolone antibiotics, like levofloxacin, can potentially cross-react with some common opioid immunoassays. Some other ones you need to know about is antidepressant trazodone affects immunoassays for fentanyl and ecstasy. Promethazine affects the immunoassay for amphetamines. And proton pump inhibitors affects the immunoassay for marijuana, THC. So opioid metabolism may explain the presence of apparently unprescribed drugs. So clinicians ordering urine drug tests should also be aware of the metabolites of the drug that they're prescribing. For example, codeine is metabolized to morphine. So both substances may occur in the urine following codeine use. A prescription for codeine does not normally explain the presence of only morphine. Prescribed morphine cannot account for the presence of codeine. Coding alone is, however, possible because a small portion of patients, about 7% of Caucasians, lack the necessary CYP2D6 enzymatic pathway to convert codeine to morphine. Morphine can also be metabolized to produce small amounts of hydromorphone. Hydrocodone may be metabolized to small amounts of hydromorphone. Metabolism of codeine may also produce small quantities of hydrocodone. And oxycodone is metabolized to noroxycodone and oxymorphone. So clinicians should use urine drug testing results in conjunction with other clinical information. When unexpected results occur, you need to call a laboratory director and toxicologist, and I have one on my speed dial. Any unexpected positive results for drug misuse or unprescribed drugs suggest further evaluation is required. And most common interpretation that I see with trauma patients is often failure to recognize what they got out in the field. On the other hand, an inappropriately negative urine drug test result for a patient who's on a prescribed substance may indicate drug diversion, but it also may indicate maladaptive behavior. They may just not have taken it in the last 1 to 3 days. One should always discuss these unexpected results. The test results, their interpretation, and resulting actions should be documented so that you can follow this, and any unexpected urine drug test results shouldn't be ignored. I always tell my patients I test them randomly. Some I test more randomly than others based on what I've found in the past. So let's look at some urine drug test results. Keep in mind, there's no scientific evidence of what the dose you take, how much is going to be in the urine, so don't let the numbers fool you. This is a good one. This patient reports a prescription for oxycodone. The urine drug test is positive for an opioid, and specifically for oxycodone, and its metabolite oxymorphone. So this urine drug test is prescription with our expectations for the patient who is prescribed oxycodone. Okay, so now we have this one. This patient also reports being prescribed oxycodone. The urine drug test is positive for an opioid, but negative for oxycodone, and negative for its metabolite oxymorphone. So what could explain this result? Yeah, not for oxycodone. So this is where I get on the latest blogs in the area and see what's the price of hydrocodone and hydromorphone as opposed to oxycodone, and is the patient selling the prescription to get the other substance, whether to supplement their income or because they have a substance abuse problem. So this would be an indication of potential diversion. How about this patient? This patient was given morphine in the field, but what does this urine drug test also tell you? Oh, I heard somebody say it. Oh, well, codeine we'd have to find out. There's another one that jumps out. There's a metabolite that you want to know that we call 6-MAM. Do you see that 6? So that's the metabolite for heroin. So maybe that is involved in the trauma that brought that patient to your hospital. Okay. And finally, this patient's on a methadone program and has methadone in their urine, but not EDDP. It's the metabolite is not detected, and their urine drug test is positive for oxycodone. So how could they have methadone, but not the metabolite, and be positive for oxycodone that they're not being prescribed? So perhaps they took a little bit of their methadone tablet and they stuck it under their nail, and when they urinated, the oxycodone came out because that's what they were really taking, and a little bit of the pill was dropped into the urine drug screen, and that's why they got methadone, but since it wasn't processed by their body, it didn't show up. I didn't say that you didn't have to be smart to be a drug abuser, right? We can do a better job of educating our patients and families, and I think this is the important point I want you to take. I think most of our families don't realize that this is what's going on. We need to teach every patient that the prescription medication should only be taken for the person that it was prescribed for. We should teach them that prescription medicines are not to be used for other reasons such as sleep or emotional issues. We should teach them that prescription meds should not be used by someone other than the patient, even if for the same indication, even if it's just one pill, it's illegal and it's considered substance abuse. A common myth amongst teens is that prescription drugs are safer and to get high with than illicit drugs, and they don't perceive the harmfulness of a drug that you get from a trusted physician or advanced practice nurse or physician assistant that you then fill at a retail pharmacy right there with open lights and everything. How could that possibly be dangerous, right? They also don't understand that we shouldn't be mixing prescription opioids with alcohol because that increases your fatal risk, and that overlapping opioid and sedative hypnotic prescriptions is also associated with risk of overdose. We should also teach parents the signs of overdose and over-medication. Parents often tell me that when I give them discharge information that I'm the first one who used the D word, that if you use too much, your child could die. If your other children take this, they could die. If their friends take this, they could die. And I think this is important that they understand that there are consequences to misuse of these drugs. The ready availability of prescription drugs in teens' homes highlights the need for increased educational efforts targeting patients and parents and family members regarding safeguarding opioid prescriptions so that we don't become unintentional enablers. We should teach patients and parents to safely store their medications. So where do you store your prescription medications? Wait, let me guess. They're either at your bedside table, they're in your medicine cabinet, or my favorite is they're above the refrigerator. Because I'm 5 feet tall, so I can't reach them, but my 6-foot-tall son can, okay? So if I already know where you have them in your house, don't you think a teenager knows where they are? Parents need to understand that they need to secure these medications from their friends and family. Because much of teens' behavior is learned from models observed at home, we need to teach parents not to share their medications with other family members. However, in reality, nearly half of parents say that they have taken a pain reliever without a prescription, most for physical pain, and 14% say that they've given their child a pain medication without a prescription. And in my experiences, almost 100% of people that I see have said, well, I know my kid's really in pain because I gave him a Percocet I had laying around, and they're still hurting. And don't seem to identify that that was not normal. Only 4% of parents believe that children have used prescription pain relievers without their knowledge, but of course the data indicates much more than that. While over 75% of teens report that their parents have talked to them about beer, alcohol, and marijuana, only 23% have discussed use of prescription opioids without a doctor's prescription. Hopefully you saw in the Partnership for Drug-Free America launched their Not in My House campaign, and it's 3 steps at the last Super Bowl. I hope that they'll get a big screening at the Super Bowl again. But this gives you the things that we should be teaching every single parent. So when you are prescribing for trauma a opioid for your adult or your pediatric patients, are you giving this information to every single one of them? And are you stressing it? Or are you, as my research shows, saying, here, this is for pain, take it if you need it, or try not to take it. And then what do people do with it? They stick it in their medicine cabinet, right, and save it forever. Teens abuse prescription drugs because they are easily accessible. Step 2 is to secure it. Approach securing it like you would your valuables. Step 3 is disposal, and this is the one that is often controversial because people keep a hold on their prescription opioids, and prescription opioids are actually some of the cheapest drugs that we have. We recommend that if they're going to dispose of it, they do it when their teens are not at home. But how do you dispose of it? In September of 2010, the DEA authorized the first national prescription drug take-back program, where individuals could drop off their prescription drugs when they were expired or unused. Law enforcement oversight was provided. But an example of the success of this program, in a 4-hour take-back event in a Midwestern city, they yielded 16,000 Schedule II and III dosage units. If no local take-back program is available, the FDA and the DEA recommends the drugs be disposed of in the hospital, in your household trash. First, they recommend removing it from the container and putting it in an undesirable substance so that it's less appealing for children and pets. Then they should be placed in a sealable bag or other container to prevent contamination with the garbage. But the FDA also identifies meds that are fatal in one dose if taken by someone other than the patient, are considered extremely harmful, and recommends that they be flushed down the toilet. Now, this is the controversial part, because everybody's worried about the fish getting high. I really hope there are not fish in my toilet. But what they often forget is if they took those pills, where would the metabolites of it end up? In the toilet. So the idea of, oh, this is environmentally harmful, well, then taking opioids is also environmentally harmful. But this gets rid of it right then and there, not waiting for a twice-a-year take-back program. Recently, the DEA expanded a drug disposal so that take-back events should be more frequent. There's going to be mail-back programs, and they're allowing collection receptacles in commercial pharmacies. Of course, that's a great cost to commercial pharmacies, so we'll see if that actually happens. Prescribers in hospitals are still not allowed to take back prescribed or dispensed medications. So let's switch gears really quickly, and let's talk about your practice. So we know that opioids are still the gold standard for moderate to severe pain. Think about, what do you prescribe in your practice? How many pills do you prescribe? And what do your patients really need to treat their pain? So this is one of my sons. This picture was taken when he was ranked 6th in the state of Texas for motocross. My mother got him involved in this sport, believe it or not. The day before I was defending my dissertation, I got a phone call. I'm gonna impersonate the guy for a second for you, and it was an EMT for Care Flight, and he said, "Ma'am, we have your son here, and well, ma'am, I just got to tell you, he's got the biggest set of balls I've ever seen." And I don't know how you're supposed to answer that, but I said, "Okay, I haven't been looking down there lately," and he said, "Well, no, ma'am. Your son, we're not really sure what happened. He was out in the field, but he came to the medical tent, and ma'am, he's in a lot of pain. There's a hospital down the road, and I can't tell you if there's a surgeon or a doctor or anybody there, and we'd like permission to care flight him to a trauma center." And I said, "Well, please do." He was care flighted to Waco, where they found that he had incarcerated a hernia and had 12 inches of dead bowel, and went through a resection, was out of the hospital in 4 days, and during his hospitalization used 12 milligrams total of morphine. So I was pretty impressed that I thought he was a tough kid before, but 12 milligrams of, he's pretty tough because he's a heck of a lot bigger than me. A year later, he had his wisdom teeth pulled out, his 3rd molar extraction, and he was prescribed 20 hydrocodone. This is Max. This is my other son. He's also kind of cool. He doesn't do motocross. He decided, he just graduated from the University of North Texas with his degree in hospitality with a minor in beverage. And his freshman year, he decided in his first semester that he was going to get his wisdom teeth pulled out, because that's what people do in their fall semester or their first year in college. And he was also prescribed 20 of hydrocodone. So remember, I asked, how long do kids hurt after surgery? How much is used? And isn't there any evidence to support this? Well, there's not a lot of research looking at what people do at home. And in fact, in one study I could find that they reported that 25% of parents did not follow the instructions that they were given for their kids. They found that patients often ceased pain medications before, or they kept giving them for a longer period of time out of fear of pain. We often think of parents as being well aware of their children's ability to manage pain and when their children are in pain, and that's true for common pains, bumps, bruises, things that you give a kiss on the knee for, but not for unusual circumstances like incarcerated hernias. So how much did my boys use? Jack needed one going to school when he'd first wake up in the morning, and he'd use one at night sometimes. He used about 10. But the other thing he did was he told me one day, "Mom, I learned from somebody else in my high school that you can get really high on hydrocodone if you mix it with Adderall. Is that true?" I don't know if it's true, but I don't know why they're discussing that instead of things like English, math, okay? Max used 2. He also called home to inform me that his buddies in college informed him that he could sell the other ones for about $15 a piece. So now think back to when you were a freshman in college and you have 18 pills worth $15 a piece, and your degree is, you're gonna have a minor in beverage? What are you thinking, okay? I remember with Max, I said, no, you can't take those. Flush them down the toilet. Oh, no, you live in a dorm. Don't flush them down the toilet. Okay, send them to me. Oh, no, that's illegal. Don't send them to me. And trying to figure out what the heck is he supposed to do. Okay. So this motivated me to examine our acute pain practices. And so we've chose to study children's pain and analgesic use at home after laparoscopic appendectomy. Common procedure, right? We hoped to gain knowledge of what they used so that we could make sure that we were matching what we prescribed, the amount we prescribed, to what people were actually used. We had funding from the Nurse Practitioner Health Foundation, and we also used electronic caps, and what they are is every time the bottle is opened, it tells us it's opened, it stores the information. When they bring the bottle back, I can download that information. So they kept a 14-day diary of if they had pain and what did they do about it. We encouraged them to tell us everything from I used an ice pack, I sat on the couch, what did you do, and then reassess their pain. We also gave them the prescription bottles to fill their medications, and we told every single one of them that cap told us every time that bottle was opened. And what I would tell them is, I'm a mom of 4 kids. I know that at 3 o'clock in the morning, you might give your child something for pain, and you might write in the diary that it's 3:28, but it's going to tell me on this cap that it was really 3:02, and that's going to allow me to verify that information. We called patients on the 1st, the 3rd, the 7th, and the 14th day after surgery just to see if they were still in the study and clarify procedures. And they were told to bring back their unused prescriptions so we could do a pill count and their diaries to their clinic visits. So this is one of the examples. On the left is the patient, your left is on the patient's diary, and on the right is what we got from the ECAP. And this is the only patient that we talked about that there was a difference in what they did, what they wrote, and what happened, because this patient had written 3 Percocets missing at 8:48. And interestingly enough, if you follow the ECAPs, the bottle was opened 3 times that was not recorded. And so I brought that up to this little boy and his mom, and they stared at each other and went, well, who could have opened the bottle? And I said, gosh, does anybody else live in your home? Anybody else ever been to your home? Is it possible? And you could see mom's alarms going off that perhaps she now had an explanation for where those 3 Percocet were. We actually found that of our 100 patients we're now done with enrollment, only 40 actually brought back this material, and that of those 40, there were 14 cases of unexpected findings. So these graphs show the maximum pain scores recorded each day after discharge for 34 of the patients, and we use a scale of 0 to 5. The red, that dark red, is the 5s, and you can see that the number that are reporting severe pain does not match with how many doses of how many of them are actually taking prescription pain medicines. The other thing that jumps out is, there are the patients who take it up to 7 days, and then we've got this patient at day 10, and I'm going to show you that patient at day 10. So here he is. And this was also a really honest patient, and he explained what he was doing, and then he wrote down that on day number 10, he fell off a hammock and took the hydrocodone for chest, belly, and groin pain after his fall, not for his surgical pain. We found 7 cases of what we are describing as late openings, meaning 3 to 15 days after they had not used another prescription product. And what's amazing to us is that all of these occurred on Fridays, Saturdays, and Sundays. Now, I'm a researcher, so statistically, that's 3 out of 7 days, but it is kind of interesting, isn't it, that it wasn't Monday, Wednesday, and Thursday. Okay? Here's another patient that said they had no pain on day 7, last analgesic was ibuprofen on day 6, the ECAP was opened on day 9, and 3 pills were missing from the pill count. So of 4 of our families also reported that they didn't fill their child's prescription, but when I went on the prescription monitoring program, 1 child was dispensed the medications in that child's name on the day of hospital discharge. So I don't know who's got those drugs, but that's what this number 9 is. Those are the 20 pills that the family said that they never got because they didn't fill the prescription, but they're out there somewhere. Of 552 pills prescribed to 38 patients who reported partial or complete data, 515 pills were dispensed, 208 pills were reported used for reasons prescribed, 42.5 pills, 8%, were unaccounted for by pill count, and 264.5 pills 51% were returned to the 29 patients, 29 families for their disposal. And I had a medical student working with me on this, and she actually got to see patient number 2, and we already had some data by that time, and she called me and she said, I can't give him the pills. Dr. Manworren, I can't give him the pills. And I said, you have to, legally you have to. And she's like, no, I know that they're not gonna go where they have to go. And I said, well, when you have power of prescribing, remember how many you prescribe. We did have one patient who got 45 pills. So you can see a dramatic range in what we were giving for this procedure. So how do I want to conclude? I want to conclude with, so what are you going to do? These prescriptions have your name on them. What are you going to do with it? Thanks.